Okay, good afternoon. Well, so infrastructure. Well, I looked it up. In my office, I have the Oxford English Dictionary, which is 23 volumes at the moment. And in there it says that infrastructure is that which supports a structure. And so the question then is, what is the structure? So for me, infrastructure is society. And everything that we're actually doing here, whether we're talking about building bridges or hospitals or railways or water systems or whatever, is about supporting society and its progress into the future. So for me, healthcare infrastructure starts from that premise. So I don't start with a hospital. I start with how do we actually improve the health of society. And that brings me to a distinction that I think is actually very important, which is the difference between health and healthcare. Because for me, I think healthcare to me is a failure. And I don't mean that the people in healthcare are failures, of course. It's just that it's a failure of that supporting society, because actually we should be trying to support society to be healthy. And therefore, when I design public infrastructure in the urban realm, it is to enhance health, not to reduce it. And I think that we should be aiming to put into the objectives of all of our urban infrastructure projects, which is the sort of area I work, should be the enhancement, the positive enhancement of health. How do I make it healthy? So that sounds all a bit fluffy and academic. So what do we mean? Well, 2010, 126 people died in London as a result of traffic accidents. Very tragic. A lot of those were cyclists, as it happens, but 126 people. The same year, 9,000 people died in London as a result of respiratory diseases caused by PM2.5 and nitrous dioxide, which are emissions from diesel-engined cars in the main. Completely different ballpark. Why, I ask myself, are we creating infrastructure to enable those cars, including the engines that are in the cars and the infrastructure that allows them to go, which are effectively making the city unhealthy? So to me, the beginning of the process is, how do I actually create a city in which being in that city increases my health so that I don't need the healthcare sector? And then I can start thinking about, well, if I'm unfortunate enough to need the healthcare sector, how do I actually ensure that that healthcare sector itself is actually healthy? As a professor of infection in our university, a wonderful job title, isn't it? Professor of infection said to me, he said, well, you know, hospitals are where the sick people are. And he was explaining to me why the ventilation system in a particular design that we were looking at had been built backwards, so that they were trying to differentiate the pressure in various parts of the hospital so that in order to reduce the risk of infection, but actually they simply increased the pressure where the patients were and decreased it where they weren't, and therefore every time you opened a door, all the infection would rush out and go into all the places where it wasn't, and then was circulated very nicely around the hospital. And the best time that he had his best success on infection reduction in the hospital was when they switched the entire ventilation system off, because there was a building work outside and they had to open the window. And I think what I'd like to see is a sense of putting the objective into infrastructure design that says, let's actually look at that health question first. And then everything else then follows, and we can make our decisions afterwards as to how we do that. And I think we should be introducing that sort of concept into the way in which we educate our engineers and architects and planners and so on, so that that becomes one of their principal objectives, rather than worry about budget, time, whatever. Health comes first. That's for me. Thank you.
Hi, everyone. Good afternoon. So I am going to be speaking and giving some broad strokes and framing around why is economic and social equity important to our healthcare infrastructure, but also more broadly to all of our infrastructure and all of our systems. And wanted to will offer some key considerations for how to think about incorporating an equity and justice lens into your work, in order to transform infrastructure and in particular healthcare in a way that will benefit all. And I'm going to actually lift up a couple examples that we have seen across the country here in the U.S. That we see as very promising practices for how to transform the healthcare system in a way that really is equitable. But before I start, I just wanted to share a little bit about PolicyLink. PolicyLink is a national research and action institute that focuses on advancing economic and social equity by lifting up what works. So we believe that our local leaders are our national leaders and really take examples in the good work that all of you are doing and lift that up to the regional and federal level. So I wanted to just start with this picture here of two trees, and just to point out that the fact is that, and we've talked about this, I think, throughout the day, is that society and decisions that we've made has created unequal communities and places, where in some places that we see is a thriving tree, where disease and unhealthy conditions are relatively reduced. And in other communities, we see that there are huge epidemics of disease and chronic conditions. And, the healthcare system really has been focusing on the leaves of the tree. But when we're really trying to think about fundamental transformation of the healthcare system and infrastructure, we really need to get to the root of the tree and really looking at the social and economic determinants. And that includes transportation, housing, food systems, employment, segregation. All of those things are really what really are going to determine whether somebody lives a healthy life or not. And I believe that the research shows that medicine or healthcare is just a small slice of how we can really make transformation, but it's really about 60 to 70% of the influence on how to create healthy lives is really around those determinants. So the way that PolicyLink, our definition of equity is just and fair inclusion to ensure that everyone can prosper and lead a healthy life. So therefore, health equity is the attainment of the highest level of health for all people. And actually in our previous session that was here in this room, one of the presenters said, what we really want to make sure doesn't happen is that a good thing becomes the elitist thing. And that really is what equity is about, to ensure that everyone can benefit from the decisions and the development and the infrastructure transformation that we create. So just an important distinction to make between inequality or equality and equity. Imagine equality is if I gave everyone a pair of shoes in here. But equity is if I gave you a pair of shoes that fit. So equity is really about ensuring that the policy, the proposal, the development that you are creating is actually going to fit that community in a way where those that are there are going to benefit from it. And that to ensure that it's working for everyone, not just a few. So why does equity matter more than ever? Well, one, the face of America is changing. We are now going to be the minority populations in this country will be the majority by 2042. We're also seeing that income inequality is high and persistent. And we also know that low-income people and people of color disproportionately experience lack of quality healthcare services that then promotes and increases health disparities. It's continuing to increase the costs of healthcare in this country, and we're seeing productivity decreasing. So if we really want to see dramatic, sustained improvements in our healthcare infrastructure and in all of our infrastructure and systems, we really need to put equity, racial and economic inclusion at the heart of our strategies to ensure good economic growth, to ensure competitiveness and prosperity in a good, healthy nation. And again, the significant savings that we're really searching for as far as our health care is not going to come from medicine alone, but it means addressing those root causes and those social and economic factors that lead to unhealthy lives. So actually, Mr. Powell really was addressing this in his comments about understanding the internal system and dynamics within our own infrastructure. So just alone in our healthcare system and in other systems, there's a lot of conflict. And there's a lot of things that we actually don't really align very well, much less do we align it in a way that is actually going to lead to equitable outcomes. So when we think about equity in the context of healthcare or any other infrastructure, it really is, I think what Dr. Wegner said today during lunch, it's both about the process, but it's also about the systems themselves, the policies and the practices and the outcomes that you're seeking to achieve. So it's both about the means and the end. So when you think about an infrastructure or a system, there's all these pieces to the system. There's relationships, there's data, there's language. I mean, just alone between healthcare and transportation or development or housing, we all speak very different languages. So how do we make sure that we address those language conflicts? There's also conflicts of interest. There's conflicts of values. And there's structural conflicts about how do we make sure that we actually set up a system that is making sure that we're actually in the places that we need to be in communities, that we don't have some sort of equal power imbalance between the system and the communities themselves, and that there isn't unequal control of resources. You know, budgets are an extremely powerful tool and can really create major change if we really take a second look at how we prioritize resources in our communities. And I would say that, you know, the ACA, the Affordable Care Act, is really pushing us to seek new reforms, to really create transformation in our system, to create new opportunities for connection, to create new opportunities for alignment. And I think more importantly, and I think we've heard this earlier today, is to create a new framework by which we talk about our infrastructures and our systems to be more equitable and just. So one big component to the process of equity and how we create an equitable healthcare infrastructure is community engagement. And so real transformation is going to happen if we engage those that are experiencing those health disparities and also the ones that are the consumers of the health services. So part of that means really looking at how do you go about engaging with community residents and those that are around your clinics and hospitals and other health services. You know, one big distinction that's important, outreach is not engagement. It is one thing to go to a community and say, you know, we've come up with the plan. We think it's really good. What do you think? 9 times out of 10, when I've seen that process, the community says no go. It doesn't reflect what we need. It doesn't reflect what's important to us. Try again. But when you have meaningful, authentic engagement, it means having members, community members at the table with you, co-creating that transformation and that vision for a new infrastructure. So we created what's called this sort of ladder for community engagement. And I would say as a public health trained professional and researcher, we love our focus groups. We do so many of them. And they're great. But the limitation is that they're a one-time opportunity for input. That is not meaningful engagement. And so when we really think about creating and shifting power dynamics and ensuring that those that will have experienced disparities are also part of the decision-making process, we need to think about ways for them to really engage at the governance level, for them to be part of the decision-making processes from the very beginning. And so the question is not only how do we get people at the table, it's also asking yourself, well, what table are we creating? So here's one example that I think is quite powerful. So under the ACA, you know, there's now this requirement to conduct community needs assessments and also to create, you know, health improvement plans based on those assessments. So in Worcester, in Massachusetts, they went through a really extensive community engagement process where they conducted almost 2,000 individual interviews. They also created an advisory committee that included community residents as well as the health department, hospitals, and other community partners. And one of the key components that came out of this engagement process was to lift up a key priority for their plan, which is health equity and the determinants of health. And as a result of this collective community engagement process, one of the key domains of their plan reads as such: to improve population health by systematically eliminating institutional racism and the pathology of oppression and discrimination by promoting equitable access to and use of health-promoting resources in the community, and significantly reducing the structural and environmental factors that contribute to health disparities. Now, I don't know about you, but I don't think I've ever seen any health improvement plan that includes language around institutional racism and oppression. So in and of itself, that is in a plan, that sets now the path for accountability. And now the same advisory group that helped to develop the plan and those same community residents are there to implement it. So really powerful work happening here. Now, the other piece to equity is to then think about the actual policies and practices that you want to put in place. And for the most part, I think that the way that we've considered our healthcare system is around the programs and services that we provide. But we also need to think about those midstream and upstream factors and ways to influence and change the system and really creating equitable policy change. So the way that we like to frame it is both thinking about health in all policies and in all different types of systems, but also equity in all policies. How do these policies either produce positive or negative impacts on low-income people and people of color? So one example of this, and I'll just say, I think particularly for the healthcare system, procurement is a huge issue, but it's also a huge opportunity. Anchor institutions like hospitals, universities, government agencies, they are important regional economic actors, and they own significant amounts of land. They're major employers. They spend billions of dollars of goods and services, but yet those billions of dollars never make it back to their own backyard and in their own communities. So really what we're trying to look at is how do anchor institutions like hospitals and health systems leverage and harness their economic power in a way that really is about economic inclusion and equity. So when we look at Cleveland's Evergreen Cooperative example, they really exemplify how anchor institutions can orient their spending power in a way that spurs business development for the most distressed communities in Cleveland and connect low-income people to good jobs that pay a living wage. And so they've developed 3 businesses so far. One is the Evergreen Cooperative Laundry. The second is the Evergreen Energy Solutions, which is doing a lot of work around retrofitting facilities. And the third is the Green City Growers Cooperative, which is a hydroponic greenhouse that is growing produce for the hospitals. So they've created dozens of jobs. These are also employee-owned enterprises. So there's wealth building a component to this. And the jobs themselves, over half, have been filled by those that have prior felony records. So really, again, another way to really transform how we do our work. Couple last examples. One is the Healthy Futures Fund, and this is an approach by philanthropy to bring together the housing system and infrastructure and also healthcare. So Morgan Stanley, the Kresge Foundation, and the Local Initiative Support Cooperation, or LISC, have launched a $100 million fund, I think this was in 2012, to expand access to healthcare and affordable housing, and to fund these services in a way where they're actually linking together in underserved communities. And this has been a direct response because of the ACA. So they've built 500 housing units, and also with them have integrated health services and constructed a few federally qualified health centers to spur this collaboration between health and housing. And the goal is to actually create about 2,200 jobs just from this initiative. The other is the Fresh Advantage. And so this is actually an organization that provides technical assistance and guidance to hospitals and healthcare systems to meet their ACA and the IRS community benefit requirement by developing community programs that are used for food service operations. So they're really focusing on how do you look at data to ensure that you're really understanding what the food insecurity issues are in the community, and then to actually implement programs to address those issues. So that could mean at hospital sites building clinics with grocery stores, gyms, and actually even creating gardens that produce vegetables to then go back into the hospital. So I'll just end by saying that this approach in the lens of equity and justice really requires disciplined execution. It is all about intentionality, because it is also a very different way of working together and about thinking about the issues. It requires a new level of accountability, and it requires us to really both align within our own system, but also across systems as well. And then lastly, I would say that it really just requires us to stretch outside our comfort zone and talk about issues around race and racial and economic inclusion as the way forward for more robust economic growth in this country. So with that, I'll end.
Unfortunately, Bill Vanderpool has had to send along his regrets. I'll make a couple of key comments, though, that he wanted to share with the group. But he sent along four messages and kind of trends that he's seeing that I thought would be very worth sharing. And as a reminder, Bill's background, he's a hospital pharmacist and has been a leader in both in hospital, home health, and managed care settings. So this is from his perspective. He's seeing a major shift in emphasis underway from treating illness to managing overall population's health. So quite consistent with what we're hearing from our first two presenters, Nick and Amanda. He's seeing a further continued emphasis on cost reduction in healthcare spend. These are leading to healthcare providers scrambling to shift their care to an outpatient environment for many services. So outpatient care tends to be less costly. However, as in any ecosystem, what kind of consequences is that shift going to start creating? He also, in close, finally sees a need to make health and wellness practices as fast and easily accessible as we have made unhealthy practices in recent decades, like fast food, processed food, and takeout delivery. And while he would say this likely needs to be undertaken or even driven by individuals, employers, and healthcare providers, he sees this presenting a significant motivation for the healthcare system. So some of these anchor organizations that Amanda was talking about.
All right. So I actually really appreciate you bringing in Bill's perspective. I will sort of actually weave together a little bit some of the elements that we've heard, both in terms of the migration towards population health models, what it means in terms of how can we actually focus on systems and models that keep us healthy, and how do we do that through addressing some of the social determinants that sort of affect our overall health. I think I have slides.
And if you advance.
Perfect.
Yes.
All right.
I'll look on there.
I wasn't intending to use slides to begin with, so this is probably the universe's way of just telling me I should never have oriented myself to slides to begin with. So the first thing is that I'm Chief Market Maker at the Business Innovation Factory, and so I want to say a sentence about what that actually means. In the world of business and the world of enterprise, the world is basically divided into, I think, two types of leaders. One are sort of traditional share takers. Their goal as leaders is to figure out how they can get a greater share of the market. And then there are folks who are the market makers, and they're not really actually caring all that much about what the existing market is doing. They're trying to create a whole new standard, a whole new way of delivering value. So we call those market makers. So basically, I work in complex social systems. I work in government, I work in education, I work in healthcare. And my job is to help leaders in those systems be market makers. So, when we sort of think about market makers, the kind of traditional analog or the sort of the examples are, your share taker is Blockbuster and your market maker is Netflix, or your share taker is a taxi company and your market maker is Uber. Right? So a totally different way of organizing to deliver value. In social systems, what that means is I'm sort of really focused on how do we actually design the new models that have a chance, an actual chance in hell of helping people be healthy, of helping our students get really engaged in their education so they're building skills, competencies, and capabilities and not just trying to get through college with a degree program, or helping citizens engage meaningfully versus just showing up to vote, right? All of these new models have consequences for how a system develops, and that's the infrastructure piece that I want to sort of take a couple of minutes to reflect on. The first is that I do work in the world of business model, which is a set of capabilities and a sustainable financial model in order to deliver value for a target audience. Capabilities would be people, processes, and technologies that are required to organize and deliver value. A system is a network of business models connected through a sustainable financial model in order to deliver value for an entire customer segment. I want to basically speak through an example of a project that I've been working on for the last 3 years, and it's a problem that I think is pretty universal in healthcare, and it speaks to some of the trends and some of the innovations that we're going to be seeing. So this project is in Dallas, Texas. There's a lot of great things going on in Texas, and the client used to be Children's Medical Center of Dallas and has changed its name to Children's Health System of Texas. One, to sort of reflect some of the changes in its overall business model and how it's going to provide value to users. So if you look at the left-hand side of the picture, that's a sketch of the hospital. And it reflects, it's a great institution. It's a beautiful institution. It's right next to Parkland. We saw Parkland sort of go up and the construction happen while we've been over the course of the last 3 years. So we're sort of in the shadow of Parkland. And Children's is basically sort of what the medical center is facing. It's a great hospital. It's one of the top 5 children's hospitals. It's got a great trauma center. It's sort of really well known. Increasingly, it is serving in its emergency department. It's serving people who are coming for probably issues that don't require emergent care. They're coming for primary care, and usually those are sort of issues related to pulmonary or respiratory or metabolic related conditions. And so children sort of looked at it through their current business model, which is a sick care model, and sort of began to and basically said, okay, so the question is access, and the question, and it's for these populations. Let's take our sick care model, let's miniaturize it, and let's bring it to communities where there's need, so we can answer that access question. And so they built, so it's the right-hand side of the diagram, they built all these little mini ambulatory outpatient centers where they could do a lot of the preventative care. So guess what happened? Emergency usage didn't go down. People continued to come to the emergency department, and most of these ambulatory centers remained empty. So it's not about brand, it's not about sort of positioning, because Children's has a great brand and great market share. The question was, are we actually really meeting a user need? What is the job of healthcare that would actually keep people healthy? So that's where we came in. But what I do in terms of designing new business models and helping companies or helping institutions kind of develop a new model, the first is that they need to shift their lens, right? If you don't shift your lens, you can't come up with a sort of a new way of providing value, much the same way that Children's focused on building, just taking its existing business model, which was a sick care model, and then, and taking that model and shrinking it and changing it or not changing it. So I basically marry human-centered design, which is I am a behavioral scientist. I'm also a designer. So I marry the sort of the process of understanding what is a job that people actually need us to do, what is it that they're actually going to do, what's the difference between what they say and what they do, and use that as the base for understanding, for inspiring new possibilities. And so when I sat down and talked with folks about what health actually means to them and how they, and again, sort of not focused necessarily on healthcare, but what health means to them, it was physical health was an element of what it means to them. But really, it was sort of much more about their overall well-being, and there were all these sort of interconnected elements that are sort of that work on a spectrum that go into how well we actually feel. And so this got us thinking actually sort of about this key question about, we talk a lot about wellness activities in healthcare, but they're bolts on to the existing system. You take a sick care system, then you ask it to provide preventative care and wellness services, which it doesn't actually have the capabilities to do. So it doesn't have a core competency around that. So we began asking the question, what if we turned it on its head? And what if we decided to start building a business model that had wellness at the center and sick care, because people get sick, sort of more as a supporting capability? What would that look like? So we're basically trying to sort of figure out how do we make these things real and actionable. So we translated them into a set of jobs to be done. What was the customer actually asking us to do? And this is sort of pretty wild work for a healthcare system to be doing, because it's sort of begging the question, if we're not in the sick care business, what business are we actually in? And that gets to Amanda's points about sort of there are all of these external factors that contribute to people's poor health. And I work with a number of healthcare industries, and they talk about our healthcare systems, and they talk about we want transformational ideas and models as long as it's within healthcare. And the fact is that we can't actually get there from here. If we really want to improve people's health, we need to stop thinking in that way and thinking through that lens. So translated sort of all those things into a theory of change. When I talked with families about when I talked with them about wellness and what that would actually mean, the thing that I realized is that there's no end state, right? So if you generally think about health, it's in a sort of very, you sort of measure it in a very traditional index in terms of things like your BMI, your blood sugar levels, sort of like, all of these very traditional physical things, right? And there's a good zone and there's a bad zone. We're sort of focused on wellness and well-being, and what does that act like? Most families sort of said there's no end state, there's no ideal state. We're just in this constant place of improving our overall well-being, and that resonated with me because I'm generally a healthy person, but I don't always feel well, and I go back and forth. And so, if we're thinking about this as a kind of a complex thing, we had to take a complex sort of theory of change. So we basically created, we were sort of recognizing that well-being is an emergent state. And therefore, in order to create the conditions and create the sort of supporting infrastructure, we need to support it as a complex adaptive systems, which means that we need to focus less on what the infrastructure is, or actually that's not true, we need to focus on the infrastructure, but what it means in terms of how we create conditions and recognizing that it's not a top-down, let's build the bricks and mortar, and then everything's going to sort of like we can do it within that. We basically needed to create sort of more emergent ways of behaving as a system. So we began thinking about what are the rules? When people interact with each other, what are the rules? What are the roles that are really important to this process? What are the signals? How do we signal, what's going to happen? What are the signals that enable trust? What are the signals that enable engagement? What are the tools that we're going to use, and what are the interactions we want to support and try and negotiate? So all of this has implications, obviously, for sort of both the data systems, the physical infrastructure that are required to support, a more decentralized population-based system. So based on that, I am a designer, so I have a bias towards action. I learn by doing. I organized families in Dallas, and we co-created. Co-creation is a big word for us. Two programs, just two prototypes, to determine whether or not I could create the conditions and an emergent set to improve family well-being. So the first was this sort of great program about self-actualization and community contribution called Your Best You. The second one was a pop-up healthy lifestyle experience called What's Cooking. Both of these programs, as I said, they were co-created with families. So it's a sort of, they were by families for families in Dallas. And they were very clear on that. We put together an index called the Family Wellbeing Quotient that had 100 different behaviors that we were observing, measuring, and collecting micro-narratives around, so that we could actually understand, and the data was both signaling data, which I think gets to your point earlier about what are the signals that change is happening or not happening, and then there was confirming data, what were the behaviors that would confirm that change had happened. And in a very short amount of time, we saw a pretty significant change across all of the elements of well-being in terms of improving them. We saw a greater change amongst youth than we did see amongst adults, though both were significant. And the most interesting thing is that with the families, we saw sort of this really interesting adult-kid thing happening, where there was the greatest change with adults, which is the sort of top. We saw these are actually inverted. We saw the least change with children. Where we saw the greatest change with children, we saw the least change with adults. And so we sort of recognized that, again, the family itself is a system that we needed to take into consideration, which is incredibly hard when you are a children's hospital and you serve anyone who's 0 to 18, but when you get out of 18, you don't care about them. You serve them as individuals. You don't serve them as families. You don't even if you're focused on children, you don't think about them as siblings, right? Kids and families, they are part of a system, and their behaviors are learned within that system. So it's really incredibly important that we think about how does that family system interoperate. So this gave rise to sort of a theory of action. We actually now know what are some of the signals, what are some of the roles, what are some of the tools, what are the interactions that are important for inspiring family well-being, right? How do we create these conditions where family well-being emerges? And so there are a couple of things that are really important about these findings. So the first is that these findings, obviously we just did these 2 prototypes. The next stage, and just to learn very quickly whether or not we could move the needle on this. The next phase of this is actually figuring out, given that, how can we build a business model that supports it and build a business model for children's? But more importantly, how do we build a system of providers that are what we would call unusual suspects. They're not healthcare providers. So how do we sort of recognizing how important job creation is, recognizing how important air quality is and housing is, recognizing how important wellness institutions like the YMCA are, and we understand the role that they can play. How do we network them together into a system that can actually improve the health of a population? And that's what we're trying to do. So if we believe that one institution alone will do it, even one giant health system, it's not going to happen because it is this interconnected set of issues. So there are a couple of things that were really important in terms of infrastructure that enables this to happen, and that enables family well-being to emerge, and enables this system or this network of business models to develop both in an emergent but also in a sustainable and repeatable way. So the first part is that an integrative design process. So more often than not, people design in a silo. So they either design for their organization or they design for their particular unit. In sustainable design, we sort of see this as a regular issue in that you have marketing comes in and gives a set of specifications that's handed off to the designers who put together a design, that's handed off to the engineers who put together a great set of schematics, and that's handed off to the manufacturers, et cetera, et cetera. So the challenge is that creates leakage and it prevents system-wide learning. So if you were to kind of imagine, how do we bring the YMCA together? How do we bring the healthcare system together? How do you bring the police together for community safety? And actually sort of like bring them into an integrative design process where you have all of those representatives from those folks on the continuum of designing new healthcare models or new systems of support for the community. So it's an integrative design process. We also, and this is sort of one of those findings, funny findings in terms of both interactions as well as space. We need to basically create familiar interactions and familiar spaces in order to practice self-awareness, which is key to well-being. But we also need to create unfamiliar spaces and unfamiliar collisions in order to get people to sort of stretch and grow. So it's like the metaphor of a muscle tearing through exercise, and it needs the rest in order to actually rebuild itself. So we need to do that. We need to sort of build kind of unfamiliar and familiar interactions and spaces into our systems design. We need open data linking across populations, not institutions. So again, most health systems design data systems through the lens of the institution, which doesn't actually serve the individual. And we need to be collecting data that's not just about the individual's health. We need to collect data that is also sort of, about a whole bunch of other factors, which are sort of existing IT structure don't give us the ability to do. Related to that, we need to explore sort of we need to explore some issues around user-managed identity as a sort of a different way of thinking about individuals and populations. So Parkland actually has a great Institute for Innovation who's done some really fantastic legal legwork. They put together a manual of this big of sort of like how do we work outside of HIPAA for dealing with doing some of this cross work. I think that there's sort of other ways in which we can do that sort of really focus more on decentralization. Obviously, we need feedback loops to assess health of networked business models, right? So it's not just, all of us have metrics and data systems that assess how our own organization is doing, but not how a network of organizations is doing, not how a system is doing it. And until we get there, we're not going to be able to identify the holes in the infrastructure, the holes in the network. We're not going to be able to assess where the system is performing and where it's not performing. And then we need opportunities for choice and trade-offs. There's sort of some funny things about our health system that kind of violate basic economic principles of scarcity and price theory. And so we need to sort of create opportunities that actually put individuals more in charge of their own health. And that's a different system than we have right now, which is much more of a quarterback driven system. So I think that those are, for me, as I just, again, in the work that we do, these are the horizontal capabilities or the infrastructure that really will enable population health to emerge, which is really quite different thing than just thinking about how does a healthcare institution provide health to an entire population. So that's all. Thanks, folks.
Well, I hope that has been helpful. I was really inspired by each of these individuals and conversations I've had, both because I think there's been a lot of focus on the challenges that healthcare delivery and healthcare as a system has had. And I think as a number of the panelists have mentioned, in large part, it may be because we haven't been taking as holistic and systems a view of the problem as we might need to. So I'm excited listening to these folks, and I'd love to get some reactions or questions from the audience about some of the systems perspectives that they're positing and some of the innovations and the way they're both stepping back and reviewing through different lenses the problem space that we're looking at with healthcare infrastructure, and also kind of challenging our ways of innovating and way forward. So any questions from our audience? I'm curious, show of hands, how many of you in the audience work with, do research around, or in any way kind of touch healthcare? Okay. As far as what was presented today, has anything struck you as new or different? Have you guys all does this all seem like old hat? We're resonating with this, please.
So I don't know if you're aware of this sort of feedback thing, the results you have about the parents moving forward, the kids down, and that dichotomy, it it's really interesting because about 30 years ago, a guy named Ralph Levine, a psychologist, used to study family dynamics using the system dynamic differential-based approach. So I don't know if you're familiar with that work. And that comes from psychology, and that's led into related work on dyads using the same kind of model approach, the same kind of formalism to study how people go back and forth. So I wasn't actually surprised by that. I was actually accompanied with you found what you found because it makes sense in some ways. This is a comment. So my question then is, were you informed by that type of literature in designing and thinking about the approach to measurement?
Yes, and we actually had, after we sort of had done our own research and sort of qualitative research working with groups of families, we then basically did a lit review to see how did that compare with concepts like resilience and toxic stress and, and a whole bunch of sort of like other key trends that are out there. And saw like really saw great sort of parallels in that. So we teased out the things that were different and the things that it sort of like tried to figure out how, what's the world in which these things coexist. So there wasn't just sort of looking for things that validated our point of view. But yeah, definitely very much informed by it, but informed after we did the qualitative research.
Yes, in the side here.
I'm Keller from Virginia Tech. I think what you guys have done is just really exemplified what the problems really are, is that there is this interplay between health, healthcare, wellness, and we're stovepiped in how we think about infrastructure, how we think about the data. It's healthcare, it's health, it's physical infrastructure, it's police, technology, these sorts of things. And that the more that we can try to figure out how to break that down and get those interconnectivities at an adaptable and scalable level, I think would be great. I love the idea of thinking about it from a business model standpoint, because we could do all the research in the world, yet if we can't wrangle with a business model that's going to make it scalable and adaptable to reach across all of these. And I feel really strongly that it's going to be the data and the interconnectivity and the linking and the flows of the data that's going to be that parlance that pulls it together across the infrastructures.
Very interesting point. And the challenges around managing, as Ellie's bringing up some of how do you get that open and shared data across populations, not institutions? I mean, wrapping our heads around how we look at this.
Right, and as you're building those business models, how do we do that in such a way the business model is there and that the data that needs to stay open stays open?
Yes. Please, in front.
Sick care has proven to be very profitable.
Hasn't it?
Do you find a similar profit motive for wellness?
Yeah, so with the move towards accountable care organizations and the move towards you're basically taking full risk for a population's health. And so the margins are, the healthier they stay, the higher your margins, because you won't be expending care on them. So it almost creates sort of an on-demand sort of system for your resource usage. So that's the profit motive right now. There are a lot of open-ended questions because nobody has successfully done this at scale. So there's really this question about what is the how does this compare to a traditional sick care system from a business model perspective? And Children's is a $4 billion healthcare system, and their CEO had sort of said that in the next 5 years, the center of gravity is moving from the medical center being the core business to population health being the core business. So then the question becomes, how are we going? It's a significant amount of money. Is the expectation that the profit margins will be the same? And that's a big question for us that we're testing in this next phase of work. So the question is, I don't know the answer to it, and it's a big open-ended question.
But don't you? I mean, are you trying to address the fact that those profit margins are going to spill over well beyond?
Ideally, yeah, right. And so, but then there's this other question then about sort of those are networks, right? Those are that will. So can we have profit sharing across the system, given that the savings are going to be coming from a number of different places? So I think that those are some, like, again, those are some really fun questions that need to be grappled with.
I guess I like the business model. I just wonder what the business is. So one of the thoughts that occurs to me is whether we actually need to revise what we think is profit and loss in this sort of game. So, for example, we did some work a little while ago on the microbiota in the human gut. Why would a civil engineer do work on guts and things like that? And the reason is that we found some work in microbiology where people who are exposed to very small measures of microbiomes by walking, for example, past a number of small parks, had a distinctly better performing set of microbiota in their gut than people who maybe went for a few days in Central Park or St James's Park in London or something like that. Markedly different. Why is that important? It's important because those microbiota, if they improve their performance, you become more infection resistant. And so by having exposure to lots of small regular exposure to, for example, a small park, small green space, will actually do that. So one of the things that we've been looking at is incorporating inside the bus stops in London a pocket park. Some of them are called edible bus stops. Some of them are called other sorts of bus stops. But the idea is that. Why? Because we have 20,000 bus stops in London. And a fairly simple arrangement like that, which is actually extremely low cost, we do it in a very participatory way, so it becomes owned by the local community and they look after it. And so you end up with people actually being exposed to this at very, very low cost, which is actually, first of all, making them healthier and feeling better because they're not having all these low-level infections all the time. But then it starts to turn into actually you find, or potentially at least, you find fewer days off work because of sickness. And so the profit and loss model becomes a bit complicated because it's no longer I make this much money out of selling you that drug or selling you this device or giving you this treatment, but suddenly I'm reducing, lots of people are reducing their costs because they have less absenteeism from work and so on. So where does the profit and loss piece come into the business, or how do we construct a business model that includes that sort of consideration, I suppose, of what would be exogenous costs, I guess, is the way we'd probably look at it. And I think that is, to me, the challenge is how we create the business model that includes these things, because that starts to make quite a lot of other sorts of incentives make sense. And I think that would be a really interesting piece of work to do.
Well, and just to quickly build off of what Nick just said, so part of the work that PolicyLink has been doing in supporting this National Funder Collaborative, it's a collaborative of 8 philanthropic institutions and healthcare institutions. We have started to look at what is the definition of return on investment in the healthcare system, and what can we do to reframe and redefine what we mean by a return on investment to be able to capture these types of profits and gains that go well beyond what I think has been narrowly described of what that return would be. So more to come, but I think that there are philanthropy and healthcare institutions are really taking this on to be able to broaden that and really be able to say, this is actually something that is part of our bottom line, it's important, and how do we redefine that?
Thank you, Amanda. Well, I am very conscious of time. I don't want to keep you. I do want to mention there's a number of conversations happening around systems and healthcare. I've got a couple of copies if people are interested, and if we run out, give me your card and I can get you a copy of Connecting the Dots. The Association for the Advancement of Medical Instrumentation and INCOSI, the Systems Engineering Society, have been collaboratively having conversations about systems challenges and systems capacity in healthcare space. So I hope you will help us continue the conversation, but in the near term, help me thank this panel for their presentations.